Good afternoon. Good afternoon. Hello. This is great to see so many returning people. I feel like we have a wonderful community that we've established here over the past few weeks. But in case you don't know, I'm Karen Engel, and I teach at the law school, and I co-direct with Neville Hode, who is right there, the Rappaport Center for Human Rights and Justice, which is housed at the law school. This is our fourth event in the semester-long colloquium on reproductive justice, criminal law, and the carceral state. I'd like to begin by recognizing that we're meeting on the indigenous lands of Turtle Island. Moreover, I'd like to acknowledge the Alabama Coushatta, Caddo, Carrizo, Comacrudo, Coahuiltecan, Comanche, Kickapoo, Lipan Apache, Tonkawa, and Isleta del Sur Pueblo, and all the American Indian and indigenous peoples and communities who have been or become a part of these lands and territories that we now call Texas. So this colloquium is part of the Rappaport Center's Sissy Farenthold Reproductive Justice Defense Project, headed by Blake Rocap and Cristina Ramirez, and is also part of a seminar by the same name, and the students are, I wonder if you all have moved from table to table? You're still, but at these two tables here, so they know everything. If you have any questions or need to call on anyone, Ji Seon. The students have read some of the work that Ji Seon Song will present today in her talk entitled Patient or Prisoner, and that article is forthcoming in the George Washington Law Review, as well as they've read some related material on hospitals and reproductive justice. And this is just a great next step to the conversations that we've been having. The students will have a chance, as always, to ask the first few questions, but there will be time for everyone to engage. So it's my pleasure to introduce Professor Ji Seon Song to you. She is assistant professor of law at the University of California, Irvine School of Law, where she teaches criminal law, criminal procedure, and a seminar called The Carceral State. Her scholarship, which has been published in top law journals, examines the deployment of policing authority and the corresponding effects on racial, minority, and other marginalized groups. Before joining academia, she worked as a public defender in California, and these are just a few of the things that Ji Seon's done, but a public defender in California and a senior policy advocate at the National Juvenile Defender Center in Washington, D.C. So that experience and much more will be apparent in the talk today, as well as in the Q&A, where we'll have a chance to even ask her about additional things. After Professor Song speaks, we'll hear from our colleague and affiliated faculty member, Dr. Snehal Patel. He's assistant professor in the Department of Internal Medicine. He's been here before. He's great. He's gonna, yeah. We love having him here. And I was trying to make sure that I get his new position correct. So he is assistant professor in the Department of Internal Medicine at the Dell Medical School, and has been for since it opened, and is also now associate director of post-acute care at home at Central Health. So he's practiced medicine in hospitals for a number of years and is deeply committed to social justice there and elsewhere. So I'm really looking forward to each of your remarks and the conversation that you'll have together. But please join me now in welcoming Ji Seon Song.
Thank you, Karen, for that very warm welcome. And I've had such an amazing day so far, having lunch with the students and people at the Rappaport Center, and then also being able to engage with my work today with you, with all of you. And so first of all, I will state the obvious. I am not a doctor like Dr. Patel. Never went to med school, and yet here I am talking about the intersection of criminal justice, or the criminal legal system, and the healthcare system, specifically hospitals. So I wanted to start with a little bit about how I got there. So in my time, I was a public defender for about a decade, and it was specific incidents as a public defense that suddenly opened my eyes to the role that hospitals play in policing and in correctional health care. So this one day I was actually driving home to Oakland, and then I got a call from my supervisor that my 15-year-old client, who was in runaway status from a group home, had been shot by the police. Could I go to the emergency room and see what was going on? So I head to Highland Hospital, which is trauma level 1 facility in Oakland, and I go to look for my client. The hospital doesn't let me in. They tell me that the police have imposed a blackout, no visitation is allowed, lawyers included, and neither can his mom or his grandmother. So, me being the lawyer I am, flexed all my lawyerly skills to get the hospital to let me in. And as soon as I went in, I realized that there was conversations and interactions that had been had before I got there that definitely shaded the way the treatment team viewed what had happened with my client. My client had been shot in the head. He was 15 years old by a police gun. It went through the back of his head, out his frontal lobe. He lost one eye, and the bullet was lodged under the other. And it was a tragic story. For 3 weeks, I sat at his bedside, but then it sparked a world of questions about why were the police allowed there? Why were they allowed to impose conditions on me when I knew, because I talked to the prosecutor and the probation officer, that there were no charges forthcoming? And so this is how I embarked in what is now, I think I'm now in my 5th or 6th year into this research. And so that research and those findings also made it very unsurprising to me when 2 months before Dobbs came down, when Lizelle Herrera got arrested for suspected murder here in the Rio Grande Valley in Texas, I was not surprised at all. Because the research that I had been doing for the last few years made me realize that we have a lot to be worried about here in terms of how much law enforcement and policing are entangled in our healthcare settings and with our providers. My findings, up to that point, that there are erosions and gaps in healthcare settings, that medical professionals play a pivotal role in assisting police with criminal investigations, have unfortunately great relevance to this current moment, especially as it affects poor women, racial minority groups, and women of color who are already subjected to enhanced policing and surveillance. So there's been a lot of attention immediately after Dobbs came out. There was a flurry of both news. I was getting interview requests and from scholarly circles about the concerns about law enforcement surveillance and the ability to get data. So we heard a lot about period trackers, messaging apps, and other ways that are rapidly advancing technology, and the data amassed from that can be tracked and collected by law enforcement to launch abortion investigations. And certainly, surveillance and collection of this data is important. But my work draws away from this high-tech world of data to what I think is as relevant and as important, much closer to the everyday, especially to patients or people who are accessing healthcare in this way, to different kind of technology, to medical advancement, and to perhaps the one most valuable place for all of us that a community needs to survive, and which is the hospital. So if when now, I don't need to tell this group, the National Reproductive Justice Organization had released a study in 2022 about prosecution against women for pregnancy-related offenses before Dobbs. And the report has many points, but the 2 points that I want to highlight here is that there are many different kinds of crimes that a woman has been charged with. This is before Dobbs, such as feticide, dumping of remains, and child neglect. And second, that the information that initiated the investigations often came from hospital staff themselves. And so it's that hospital that's the focus of my paper, Patient or Prisoner. Now, in previous pieces, I've looked at the dynamics of police when they come to the emergency room, so one particular healthcare setting, and then the dynamics between the professionals at that intersection, so law enforcement on one side and the medical provider on the next. But the broader question that animated my entry into this research in the first place, which is how did this entire institution come to address the needs and interests of the actors in the carceral system, that's the question I address in this paper that you have before you. So Patient or Prisoner examines how in very important ways major institutions, hospitals, jails and prisons, and police agencies have relationships with one another that are not just incidental or situational, but systematic. Now, one way of looking at this intersection is this, like where the prisoner goes, obviously the prison follows, right? Obviously we need security to follow the prisoner. Another maybe, okay, this isn't ideal, but is there really that big of a problem? Because there are real benefits to having an outside hospital provide treatment, especially when we know the state of care in jails and prisons today. But those responses did not satisfy me. And perhaps this is because when I was practicing, I always sort of idealized and maybe like leaned upon medical ethics and public health a lot in my advocacy, especially when it came to conditions of confinement, solitary confinement, or otherwise abuse that was going on amongst policing and carceral institutions. And also because it doesn't satisfy me because the way that patients' rights, constitutional rights, are treated like flimsy advisements and how medical ethics are treated as negotiable principles, that also seems very wrong to me. And lastly, in the last 4 years, I've interviewed many, many physicians, talked to many more in the context of my policy work, and to law enforcement. And the confusion and distress expressed by medical providers, and then on the other side of it, the way law enforcement see the hospital as obviously places that they have free entree and carte blanche, motivated me to dig deeper. And so this paper is the result. So I hope what I'm doing in this paper is looking beyond that inevitability, beyond the benefits, and to critically examine what happens when police and correctional authorities enter this important social institution. My argument essentially is that hospitals are critical components of the infrastructure of mass incarceration. They provide necessary services to police in front-end incarceration, and for jails and prisons in front and back-end incarceration. But not only are they necessary and indispensable, hospitals adapt to these carceral actors, and when I say carceral actors, I'm talking about both police and correctional institutions. Now, why do I specifically say and state that they are part of carceral infrastructure or the infrastructure of mass incarceration? I think it's important for three different reasons. One, it allows us to see hospital practices and actions as not just separate problems in and of themselves, but as symbiotic with policing and correctional actors. And so then you could see their actions as being perpetuations of the characteristics and problems of carceral institutions. I also think it's important because it allows us to see how hospitals adapt to penal laws and trends. And in addition, and I think this migrates from my more critical to more constructive criticism, is that I think it allows us to view how we might change that treatment of people that I sometimes call patient prisoners in this piece, people who are caught at this intersection. And so how could we perhaps fully realize the benefits of having an outside entity, like having outside doctors at an outside hospital, breach the cinder blocks of confinement and possibly ameliorate the values of carceral actors and institutions. So first, I'm going to talk about why they're indispensable. Why are hospitals indispensable? Second, how do hospitals adapt? And third, I will talk more about what I mean about perpetuating the problems of mass incarceration. First, how are they indispensable? And so they're, just as hospitals are vital to all of us, they're obviously vital to police agencies, jails, and prisons because of their core mission and ability to provide medical care. But I divide this up into, I don't just rely on medical treatment, but there's three different categories that I talk about. So one, yes, medical treatment. So there are people who get arrested, and during the course of arrest, they're injured. They could be injured because it's police-inflicted injuries, or because, let's say, there was a car accident or something. They might be injured in the course of the incident that precipitated their arrest. But also, medical treatment is really important to jails and prisons because of the vast needs of the people who are inside jails and prisons. correctional health care is woefully inadequate at times, and sometimes they just are not able to provide the kind of specialized care that incarcerated people need, especially if you get to more rural areas. A lot of prisons and jails may be places where they just don't have the personnel to provide the kind of health care that people need in prisons. And also, jails and prisons are not safe places, nor are they healthy places. The conditions of confinement are exacerbating factors. They aren't sanitary at times. There's poor nutrition. They are violent places. And as we are hearing more and more, our prisons and jail populations are also getting much older as a result of these penal policies and sentencing laws, where we have people who are now serving 30, 40-year sentences when they were sentenced maybe when they were teenagers or in their early 20s. So that's one big primary obvious reason why hospitals are necessary. But there's a corollary of this medical treatment. So I call it medical clearance. In other jurisdictions, they may call it like okay to book or fit for incarceration. And as I started to talk to more physicians, I started seeing, there's a lineup between what they do and what I used to read as one line in a police report as a public defender. And that one line as a public defender would be like, took to the hospital, got cleared for jail, right? Or it's medically clearance obtained. And so I realized that what happens is, for jail liability, I suppose, but it also makes a lot of sense from the person's health side, right? If someone's injured during the course of arrest, you don't want them to go straight into a jail where they might not be able to access a nurse or doctor later. You want them to be able to go to a hospital. But I started hearing from physicians about the problems that arose with medical clearance. Like, I had this one physician tell me, like, sometimes you can feel very pressured to say okay to book. They will have the person inside the patrol car and they'll bring the doctor out and say, hey, look, just fill out this paperwork, sign it, I need an okay to book. Other times, physicians are like, okay, I know exactly where you're taking this person, and because we see people coming from that place because of the problems of this jail or this prison, and yet I have to say okay to book. I don't feel comfortable saying okay to book, but at the same time, there's this other law that exists, the Emergency Medical Treatment Law. I always forget the full thing for EMTALA, Medical Treatment and Labor Act, that requires hospitals to screen someone who comes to the emergency room. And so there's that push where they have to, not only is a law enforcement or jail person bringing them to get this medical clearance, but under EMTALA, they're supposed to medically screen. And so you have this entire category that sets up a lot of difficult ethical issues, but also very necessary when you think about it from both a jail liability perspective, but also from a patient health perspective. And I'll just give you some concrete examples here. I was just the other day, I was at a city jail and I was talking to the police officer who was telling me this, like, sometimes people come in and we suspect that they have secreted drugs at some point somewhere in their body. So we don't do the cavity search, but if, let's say, we take them to the jail, and the jail, this one particular jail that in this jurisdiction has one of those big body scans that you can do when you go to the airport. And so if they see it, then they bounce it back to us, and then we have to take them to the hospital, right? So there's those incidents of things like medical clearance. But there's also, for example, if it's a person who's inebriated, a person who they think might be mentally ill or somehow, then a lot of times that medical clearance has to happen. So those are two related to the hospital's mandate of providing care reasons why hospitals are indispensable. And then there's a third reason that I talk much more about in my paper on police in the emergency room, which is that hospitals are really important for criminal investigations. Hospitals have patients who may be involved both as victims of crimes and as possible suspects or perpetrators of crimes. And there's a lot of evidence that can be gathered at the hospital site itself, and that's not just in terms of statements, right? There's statements that can be gotten from witnesses or the suspect. There could also be belongings that could be obtained, for example, bloody clothing that is cut off from the patient's body and is on the trauma bay floor. That could be potentially valuable criminal investigative evidence. Also, cell phones. There was a lawsuit that was filed by a clinic in Baltimore because it turned out that the police were obtaining cell phones of patients rather routinely. This practice also happens in other hospitals across the country. Other things like police taking names, just seeing the names, running warrant checks, right? And you can maybe see how this might have other implications, especially when you get to things like people who are maybe undocumented. And then there's those kind of external things that are belongings or other kinds of physical evidence, but there's also physical evidence that might be inside the person that can only be gotten, right? Or we hope the only people who are really trained and skilled to get into our body are people in the medical profession. So I'm talking here about body cavity searches that could range anywhere from the blood draw all the way to a colonoscopy, all the way to surgery. And those things can result in valuable criminal evidence or evidence for a criminal prosecution, but that require the help of a medical provider. So hospitals are indispensable. So one way in which we can then see, okay, so hospitals are indispensable, and so jails and prisons and police have come to rely upon them, is that we could maybe see that hospitals, this very major, regulated, humongous institution in our lives, that they might exert some of the ways they do business on the carceral actors themselves. But what you actually see is the opposite. That when these carceral actors enter the hospital, they enter this very complicated workplace with lots of different professionals. You have nurses, you have doctors, you have staff, you have different kind of administrative people, risk management, privacy people. You have all these different departments that are super regulated, right? I think hospitals, Dr. Patel, you would agree with me, hospitals are probably the most regulated industry, one of the most. And they also have ways in which they're adapting to that, right? So hospitals have ways to help their providers make decisions. They have checklists. When you go to see the doctor, they're probably treating you and following some kind of checklist. They have decision-making pathways or clinical pathways to help them, to keep them from, maybe to protect them from malpractice claims maybe, but also to help them with their decision-making. And their purposes are largely about managing healthcare, so they're concerned a lot about regulatory compliance. There's some malpractice concerns, obviously, and risk management and safety. So the hospitals are law enforcement and correctional officers are entering this very complicated ecosystem, but they're also changing it by their presence. And one way I think it is important to highlight is, and this is, I think in the last year, I mean, the conversation about crime and criminal justice reform in the country is evolving over the past year, right? So we have reports of crime rising and people being more concerned that police are not being responsive enough, that people feel unsafe. And hospitals are very much a place where that conversation is relevant. I think maybe in the past few months, almost every call that I've gotten from a reporter has been about workplace violence in the healthcare setting. And so that's also very much on their mind. So you can also see how, when perhaps that's one reason why hospitals are more receptive to law enforcement. And you also see how the entrance of these carceral actors can affect hospital personnel in another way. So we have these workplace safety issues, but it may make some medical providers feel more safe and secure, but it also ends up impacting patient care. There might be concerns, like the medical provider may be like, okay, you've given me a request to conduct this body cavity search, but I have strong concerns about the ethical principles here. This is violating patient autonomy. You might have medical providers who are complying because they are afraid, they may be intimidated, or they might just think, hey, law enforcement is asking me for this, so obviously it's legal and I should comply. It also may influence the flow of work. So one of the big issues in a lot of hospitals is to what extent should police be present in the trauma bay. And when I say the trauma bay, I hope I'm using proper terminology, but it's like, so let's say for the legal audience here, the ambulance comes in through the door, there is a person on a gurney, and then they're whisked into what some people call like a bulb or a bowl, or like some area in which the trauma team then converges on the patient and they perform acute trauma interventions. And a lot of these hospitals and physicians are saying, well, there are also police right there when I'm doing the trauma intervention. Now, if you've read Chavez versus Martinez, which is a United States Supreme Court case about excessive force, you realize that the Supreme Court acknowledges that this happened, because Chavez versus Martinez was a man who was involved in an altercation with police. He ended up getting very injured and shot multiple times and was taken to the hospital. And the police, the Supreme Court actually had access to all the tapes that you could hear the law enforcement being involved, from the ambulance all the way through trauma intervention. So this is not something that's just coming out of hospital mouths. You hear, in Chavez versus Martinez itself, if you read that with that kind of lens, you see police are present in trauma bays, but it influences the flow of their work, and not just there, but in other points in care. And the adaptation might also make sense because there's similar roles or similar goals. Maybe I'll say similar goals: public safety, right, or public health. Police and hospitals and medical providers in hospitals are confronted with the same kinds of issues like gun violence, drug addiction, mental health crisis response, domestic violence calls, sex assault, right? All sorts of things where their interests converge and their interests align, so perhaps this is a reason for why they adapt. But so you see that this hospital workplace is very complicated, regulated, but they end up kind of absorbing it within the workplace ecosystem with some discomfort, but being absorbed. But this adaptation doesn't just occur in I'm calling it just kind of the on-the-ground everyday reality of these carceral actors and healthcare professionals, but also their regulatory structures. Adapt in a way where the hospital regulatory structures fall and defer to the carceral regulatory structures. So what do I mean by this? Okay, so if you look at hospitals have to comply with labor laws. They have to comply with insurance liability. They have to deal with accreditation. They have health and human services. They have a whole slew of regulations that are attached to agencies that they must report to. And this is just the hospitals. Medical providers themselves have a ton of accreditation that they have to do. They have regulations that govern their licensing. And so you have this on one side, and there's a lot of, there's recent reports talking about how over-regulated the hospital industry are and medical providers. They spend way too much time and money on compliance. On the other side, you have police, jails, and prisons that are differently regulated. Some might say under-regulated, so let's just talk about why that is, because Fourth Amendment Constitution, right? The United States Constitution, the Search and Seizure Clause, or just Fourth Amendment. The Fourth Amendment largely regulates police, right? So you have police, and then you might have some regulations at the state level, and you might have internal operating procedures and policies for police officers. And then on to the correctional side, you might have an agency, but the agency, their mandate is also, it's not the same kind of agency, let's say like your health agency. The correctional agency is different, and they're also less optimally regulated too, because so much of the regulations, if you actually read them themselves, are pretty vague and very like open-ended, and then the actual operating procedures of the jails and the prisons themselves will dictate. And so I think I don't like saying that they're under-regulated, because there's lots of regulation. It's just for these carceral actors, they're just differently regulated. And what the problem actually is that there's far less monitoring, and there's far less accountability for police, jails, and prisons. So when these two things come together, what happens? So first, there's silence, right? So Center for Medicaid and Medicare Services is a branch of the Department of Health and Human Services. They regulate, they are the agency that hospitals must report to for anything where they give Medicare and Medicaid funds. That's actually a vast number of the hospitals that I'm talking about here. And I'm not just talking about public hospitals, but private, nonprofit teaching hospitals. And so you have actually this old CMS, Center for Medicaid and Medicare Services guidance from about 2 decades ago, where they acknowledge that, okay, when a person comes in on their law enforcement, they might have handcuffs or they might have these kinds of things that happened because they're in custody. We recognize that it's contrary to the regulations and that hospitals must comply with, but that person is under the custody of the law enforcement actor and is not the responsibility of the hospital. Now, if you were a lawyer for a hospital reading that kind of CMS guidance, what would your advice be to your client? Thank you, Blake. Wash my hands, right? Like, wash my hands. That CMS guidance, it's just a letter, but it's a very important signal out there in an area where there's not many signals, but it's a very glaring kind of indication about, okay, this is what CMS thinks about the people who come in or under some kind of law enforcement custody. Well, then you think about, well, how about medical malpractice, right? Well, and I'll talk about why this is interesting because you can think about the tension with the Fourth Amendment. Medical malpractice, tort liability, they're not liable because they're really acting at the direction of police, right? Well, okay, so then if that's the case, then can we then turn to Fourth Amendment constitutional liability? Well, no, then we get to constitutional liability, then Fourth Amendment is like, okay, well, but if it's for a medical purpose and not a law enforcement purpose, then really it's not a Fourth Amendment issue. And secondly, a lot of times in these lawsuits, because in Fourth Amendment actions they're ex post, right after the fact actions brought by individuals, the hospital is often not named. And actually in some of the cases when you go back and look at the early dismissal motions, it's like the patient, because the person was incarcerated or handcuffed, doesn't know who the nurse or the doctor is, sends a discovery request, there's no information about that, so then the only person they can sue or the only person they can name in that action is the police officer, so oftentimes hospitals disappear from the equation that way. And if you think about all these things that being different kind of regulatory levers or incentive structures, you see how we've gotten to this point where hospitals, the overwhelming message is, we're not going to be liable for something like this. At the same time, there is like incongruity and conflicts, and most of this you see in hospital regulations on one side, and then correctional, when I'm talking about jails and prison regulations on the other, is that you have things like, okay, for restraints, we have to use medical restraints on the jail side. When you get transported out of a correctional facility, you have to be under guard, right, which has been translated to under handcuff or guard, under 24-hour guard presence. Then there's visitation policies, which obviously are, for those of you who have been in hospitals before, there are visiting hours, but you still get visits, whereas on the correctional side, you do not get visits at all once you step out into an outside hospital, even if you might get visits in the penal institution itself. Then you also have regulations about decision-making authority, which are very clearly delineated on the medical side, and also pretty clear on the carceral side, but not exactly always followed, as I talk about in the example of Mr. Cummings further on in the piece. So I take then this indispensability and this adaptation of the hospitals to the criminal system, and I say, look, we can't just say it's incidental. We can't just say it's a stopgap measure for jails and prisons and that for policing, but that is actually what makes hospitals an integral part of mass incarceration. Because without hospitals, police would have to figure out a way to medically clear people or to get people okayed to book, or to perform diagnostic tests or evidence, or to glean other kinds of information that they might need. And correctional healthcare would have to look very different in our country if hospitals were not present. And when you view this way, I think it's a very valuable perspective, because you can see how their actions are then in line with a lot of the entrenched and serious problems with mass incarceration. So I give to highlight two ways. So one, I talk about racial subordination or racial oppression, and then the second one is I term carceral loyalty. So let's talk about the first one. So just as prisons have roots in slavery, hospitals also have roots in the same. I was doing, in some of my earlier research, I was looking at hospitals in the South, and a lot of those slave hospitals are actually some of the more established hospitals that you see today in cities across the South, or at least that these hospitals are part of these systems of racial oppression that undergird a lot of our country's history. And I highlight medical clearance as one point. So in the slave hospitals, there's a lot of examples about how either slave traders or owners would bring in enslaved people to be treated so they could go back to the plantation in order to labor. Likewise, could you not see that the relationship between the prison guard or the jail guard and the doctor with the patient prisoner who's being brought in from the facility and then being said, are you okay to book? Could you not see the kind of same triangulated relationship? And then you can also see how a lot of the ideas and perspectives and biases that you might see in terms of how people view criminals and prisoners might also bleed into the healthcare context. So here I am going to talk about Texas. So UTMB. So Texas is one example of a place where I say the healthcare system, the jail, where an outside hospital directly provides healthcare for a correctional institution. And so when I talked earlier about there could be benefits, and there are we could talk in the Q&A about benefits of having outside hospitals, because I absolutely see the benefits. But like one of the benefits could be that you have outside providers who are not cynical about prisoners, who don't have all sorts of just one-sided ways in which to view a person, and that outside medical providers don't have that. So they bring like a non-prison attitude to this. Well, you could think that, but there's actually a study that was recently done. It's actually not in this version of the paper. I added it later. A study of UTMB students and medical residents about how they perceive surveying them on their experiences with the care of people who are incarcerated. And you could see that there was a lot of conflict, that there was some generational differences between how they felt like their supervisors were talking about the patients and their discomfort with it. And there was also a lot of good language or good responses about how they felt very gratified in being exposed to a population that's so vulnerable. But for the purpose of this particular section that I'm talking about, what was also interesting to me is that they expressed freedom, or the sort of, they felt good that they had the freedom to be able to treat people who are incarcerated, because, and in one particular, I don't know if I'm not going to quote it, maybe it's a paraphrase, but that they felt free from both legal and health consequences with how they treated these people, because they knew that there wasn't going to be family that was going to be around, and they also, the people that were coming to them were coming with all sorts of ailments that they might not see in a other kind of hospital setting, and they were, as younger people people lower on the totem pole of the medical profession, were still able to treat them or to operate on them, etc. And then it also came out that they had access to the criminal history rap sheets of the patients that they were viewing, and not all, some of the students expressed a lot of discomfort with that, like, I don't want to know, but others knew, and you could see how stigma might attach to treatment, especially, and there was contrary language, like some people were like, oh, I was so surprised that this person was so nice to me, like when I know what his criminal history is. But you could also see how that might cut very much the other way. The second thing is the way mass incarceration tendencies get perpetuated. This overlap is what I term carceral loyalty. So in the medical profession, there's a lot of talk about dual loyalties, right? So there's, in the correctional healthcare system, it's like your loyalty to the patient, but then there's also your loyalty to the correctional authority or the state. Dual loyalty also arises in the medical profession when you talk about insurance companies, like the insurance company who won't okay this medical procedure that you want to do. But I think that dual loyalty, both in the correctional setting, but also definitely here, is not really the right term. I think it is actually carceral loyalty, because what happens here is that the correctional way of doing business is the one that overwhelmingly predominates. And so they might be getting, so patients who are being seen by them may be getting access to more adequate healthcare than they would be getting to in the correctional healthcare, in the inside setting. But there are costs. There are costs to the provider, like confusion, tension. There are costs to the patient's perceptions of their medical providers, and there might be actually costs to the patient care themselves because of this barrier that might be created if the patient sees the hospital provider as part of the police or correctional arm. But so what? And hopefully we can talk more about part 4 in the Q&A too, but my project isn't just about identifying and naming hospitals in this way. My work is definitely geared towards, well, what do we do about it? So I absolutely think that there is just no way we can do away with hospitals when it comes to the treatment of people who are being arrested and coming in from jails and prisons. I don't think that's likely. We could talk about that more, but I think, one, there are ways in which that could just expand the carceral system by just putting more money into getting better health care inside jails and prisons. So I offer three prescriptions, and one I'm going to call ideological divestment is what I say. And I borrowed this term from someone that I was on a panel with in one of these talks that I was doing. And I think ideological divestment sounds, when I talk about it with medical providers, it sounds a little bit more radical than I think I actually mean. Because what I actually mean is that I think that they need to reorient themselves. It's really interesting to talk to medical providers and people who are on the hospital side and to highlight for them as they're talking how much law enforcement comes up when they're speaking back to me about how they might change things. And so the challenge is not to just be like, oh, I think especially in that space, abolition is not the term to use, but to think, okay, if we think about this person not as being in law enforcement custody at all, how would you think about this patient care? How would you think about the security and safety of your staff with this patient and their patient care? And that this idea of divestment means that you have to start creating a separation between your goals and police goals and to think through it, right? Because there's going to be instances of overlap, but we need more structure and more to do away this kind of informal decision making that happens on the ground. And we already see this happening in lots of different ways across the country, from people who are like very high up in the hospital admin side to like the 2 med students who like emailed me and they're like, we want to do a Know Your Rights presentation for the kids that are being locked up at this children's hospital. So this conversation is happening across the country. But then I think it's really important for hospitals to go and identify the set of policies and the tools that hospitals have themselves to change the way they're doing business. So one, identify, do we have a hospital a violence intervention program, right? Are we not using them to the maximum capacity? So there's this one place where the HFIP is very much a big part of the emergency department, but they're getting kicked out of the room when the police are present. And maybe instead of kicking them out, have them be there to act as a buffer or act as the conduit between the hospital and act as a support person for the patient. There's that kind of way. I think a really important thing that's missing here is that hospital ethicists should have a role and help medical providers think through these issues. We talked about this at lunch, but there's a lot of medical legal partnerships out there. So have clinics and have law students and have people who are doing fellowships look at this from the policing and from this like other kind of lens than what a lot of what medical legal partnerships do now. creating like patient treatment areas and then identifying certain hospital policies, and maybe I'll save this for the response. And then, but lastly, more law. And I think, okay, you're just saying more law because you're a lawyer. And I know that more law may also make people think, oh, you're just asking for hospitals to do more. Well, the issue is that hospitals are doing a lot now, even if none of it is formalized. And I think that what the value of law in this space is to change the incentive structures. And so right now, as I said, when I asked the question about CMS, the incentive structure is not at all, in the Fourth Amendment, none of that incentivizes a hospital or risk management or anybody on the C level of a hospital to do anything. So how is it that we can change the legal structures, and how can we like increase this idea, hey, there's law here, and maybe that more law is just pointing you to the fact that law exists. And so here I'm going to talk about a few. So one, I think CMS, the Center for Medicaid and Medicare Services, needs to not be hands-off. They actually did intervene in one specific incident at a juvenile hall when this mom was not informed that her kid was undergoing procedures because the person was coming from juvenile hall, had a surgery, nobody told mom. So mom had the wherewithal and the know-all to file a complaint, and then CMS did an investigation of the hospital and was like, nope, this isn't right? So CMS already knows how to do these kinds of things. Then secondly, so CMS has these ombudsman's programs for long-term hospice care, right? So, and it's both to provide, it's to answer questions, but also to help navigate people through very complicated regulatory pathways for both the provider and the patient. Why couldn't that be replicated here? And then you could also have, this is a recent idea, but the Joint, is that in a conversation with another physician, so the Joint Commission is apparently a nonprofit organization that does hospital accreditation. And the hospital accreditation, so all hospitals get accredited through, I feel like it's like their version of the US News and World, like, you know what I'm talking about? But like, so, but in a different kind, or maybe, I guess it's the ABA, right? That does our site visits, okay. I should know, they're doing, yeah. So the Joint Commission, their hospital accreditation, could they build in some of these structures into that? So even though maybe the hospitals themselves aren't willing to bulk up their policies, but we can get some kind of movement from somewhere else. And then I propose a lot of different doctrinal shifts, but I'm gonna just talk about two, which is, I call it a little bit like, just call it what it is, legal prescriptions, okay? So if we call it what it is, and we think about the Miranda question, so a quick, if you haven't taken criminal procedure, well, I mean, everybody knows we have Miranda rights. Well, we are supposed to get Miranda rights if you're subject to custody and questioning, right? So in the custodial question in hospitals often drops out because the hospital is not considered a custodial environment. Now that I know what I know, and if I went back to my public defender ways, this is what I do. I would do a discovery request or do some investigation to demonstrate how pervasive law enforcement is with a hospital. And not just in that particular moment when the questioning is done, but how often they're referred to in policies, how often they're there, do they provide security? And then the custody question becomes absolutely relevant, right? So like there's something very discrete like that. Then there's, I'm sure you read Ferguson versus City of Charleston in this class. So Ferguson versus City of Charleston, okay, so it's a case, so there was a drug testing program that was in Charleston, South Carolina in the 1990s, and then it went up to the Supreme Court because what they were doing was they were drug testing pregnant people, and if they tested positive for drugs, they were arrested and prosecuted. Maybe subject to a diversion program, but the discovery shows that a lot of them were just arrested and prosecuted. Goes up to the Supreme Court. How do you think the Supreme Court ruled? For the patients or for the city? No, for the patients. So I have this small essay coming out because this is like Ferguson is kind of like in my brain, because what they said was that this does not fall under like a special needs kind of search that you might have at school, that the law enforcement is so entwined in the making of this policy and program at Ferguson, so the hospital is has Fourth Amendment liability. So I think that if you take Ferguson and the question of Ferguson and the holding of Ferguson by the Supreme Court and you apply it to hospitals all across the country, then you can see how a whole slew of actions taken by the hospitals are so entwined with law enforcement purpose. So I could talk way more about this than probably I should, and I probably already went past time, but I do want to end with this. So this is a problem that has been growing for decades. In many ways, I like to tell people that it's because hospitals and policing and jails grew up together. They grew up together with modernization, the development of scientific methods. And so it's then no surprise that when we're here right now and we're having this highlight on this intersection, that we have to pay attention to this. So I hope that this paper helps us chart a different path forward, one that recognizes more humanity in all of us. And Dr. Patel, I look forward to your response.
All right, thank you for the invitation to provide some comments here. Thank you, Professor Song. That was a wide sweeping analysis of the, as you said, symbiotic relationship between hospitals, health systems, and the carceral system. I want to start by saying I am not a lawyer, so I really appreciated your talk, and I appreciated sort of the larger landscape that you provided. I'm a physician, I've been a clinician for the last 15 plus years. And a lot of the way I think about this is really, the day-to-day interactions with both carceral logics and the carceral system in the hospital in particular, which is where I've been practicing, right? So I want to take just a few minutes, and I'm going to respond to some of the things that you said, but less at you provide a lot of sort of policy and legal framework for what we see now, and I'm going to sort of try and contextualize that a little bit through some clinical scenarios. Before doing that, so just a little bit about me. I trained at UT Southwestern and Parkland Health and Hospital Systems in Dallas, and so that is the public safety net hospital in Dallas. There has been a long-standing relationship between the Dallas County Sheriff's Department and Parkland Hospital. Parkland Hospital provides a lot of care for the local jail, and a lot of folks from the local jail come to Parkland Hospital for inpatient care. After that, I practiced at Duke for several years, and down the street from Duke is the Butner Federal Prison, which is a high-level medical center. And so similarly, whenever individuals from the Federal Bureau of Prisons Medical Center needed inpatient hospitalization, they often came to one of the Duke hospitals. And then here, I've been here for the last several years, and our hospital here is also a safety net hospital. In our emergency department, as you talked about, as is the case in several level 1 trauma centers, we have security on site with offices in the emergency department. We have police department on site in the police department, right? So we have UTPD. We have the Austin Police Department is often there, although I don't think they have a technical office there. And then there's a close relationship between the Travis County jail system and our hospital in particular. And so a lot of, over the last several years, spent a lot of time with a lot of folks who have been, in custody. But before even going into that, I want to talk a little bit more about the sort of carceral logics that are a big part of healthcare workers' sort of understanding of how things function in the hospital. So if you think about going down to the hospital, down the way, the first person that you see when you go into the hospital, and for most of the hospitals that I've worked at, is a security guard. Usually the security guard is armed with a gun or a taser or something along those lines. Usually there's a metal detector. That's the case for our hospital, our safety net hospital over here. So if you're a patient, if you're a family member, if you're a loved one, or you're an employee, the first person that you see going into the hospital, maybe for your day of work or to get clinical care, is a security guard, right? So that, regardless of your, whether or not you're involved with the criminal justice system or criminal injustice system, that's still the first person that you see. So that kind of really frames how we think about what is the hospital. And as you mentioned, Professor Song, right, in so many ways, health systems, hospital systems in particular, and carceral systems grew up together, and so it's not a coincidence that that's the case. And we can talk a little bit more about healthcare worker safety and workplace safety, and I know that there's a lot of discussion around this and the need for security presence, but I'm gonna push back on that, as I think you have in your piece, because there's not really any good evidence around that. So I'm going to start with a few patient stories that kind of highlight some of the points that you mentioned. So one is a middle-aged woman who has a history of trauma. In particular, she's had a history of trauma with the medical system, who comes into the hospital. She's recently been unhoused, and she comes in with a severe foot infection. On the morning after her first day in the hospital, it's about dawn, and she asked the nurse if she can sit outside the room where there's these big windows and watch the sunrise. She falls asleep in the chair, and there's a shift change, and another staff person comes up to her and asks her to go back to the room, and she says, "No, I just want to stay here and watch the sunrise." Within a minute, security is called. 5 security guards arrive. The medical team is called. And what was not an escalated situation immediately turns into an escalated situation, right? So this is a person who's not involved with the criminal justice system, certainly not at this moment, right? But the response from staff follows carceral logics, right? We're gonna the first thing, or the thing that we can think about doing, is calling security and escalating the situation. Another patient, so this is an older gentleman who has a history of opioid use disorder, or opioid use over decades, sometimes chaotic use, sometimes very stable use, long periods of time when he hasn't used opioids, and has been involved with harm reduction campaigns and various other efforts, comes into the hospital with neck pain. Initially, if you look at the emergency department documentation and the initial sort of care provider documentation, the concern is that this person is quote unquote narcotic seeking, right? Ultimately, after a little bit of time, we learn that this person has infection in the vertebrae in the neck, which is going to require several weeks of IV antibiotic therapy, right? Intravenous antibiotic therapy. So he's in the hospital, and it's unclear exactly what happened, but what we know is that he missed a dose of medications, or there was a dose of medications that he asked be administered later, and subsequently he gets a behavioral contract administered by staff on the floor. Now, behavioral contracts are more and more common in a lot of hospitals, where they kind of outline rules and rules that patients are expected to follow, or the patient can be administratively discharged by the hospital for failure to follow those rules. And those rules can be, anything from not taking your medications on time, really kind of very prescriptive. Here's what you're here for. You're not following my orders. Therefore, I have the ability to administratively discharge you. And as well as some staff safety related things. So over the course of the next few days, he tells the medical team that every day a staff member or another staff member has sort of waved this behavioral contract in front of me and said that I'm going to threaten or we're going to discharge you if you don't do this, that, and the other, right? And about a week later, he tells the medical team, "Listen, I feel so stigmatized being here. I feel like you all do, you're harming me. I'm going to discharge myself. I'm going to out of your care," right? So again, this is a person who's not involved with the justice system, not coming in under custody, but the response by healthcare employees, hospital staff, and really some of the pathways that are created within the hospital follow carceral logics more so than sort of care focused logics. We've got another patient who comes in, who's brought from jail, and they have a leg infection. So this began about 3 or 4 days prior to them coming into the emergency department after an altercation outside this person's apartment, which led to a wound developing. It was during that altercation, so a police-related incident that led to this wound. when he went to jail, was placed in some sort of isolation, was not able to see anybody for a period of time, asked to be seen by a provider because he felt like his wound was turning into infection. Ultimately, 3 or 4 days later, is brought to the emergency department. And at this point in time, right, the wound has become severe enough to where he requires surgical debridement, an extended course of antibiotics, right? So a delay in care, kind of going back to this, this point that you make, Professor Song, of, where is this role of quote unquote medical clearance? Is that even a thing? And who is left outside of that often, if that's such a thing? So another patient, so this is a gentleman in his 60s who is in custody, in jail, complains of chest pain, is brought to the emergency department, and I don't know what all happened in that visit, except to say that during that short hospitalization, the plan was for discharge back to jail with an outpatient stress test. Here's somebody that's in custody. Comes back to the hospital about a week later with chest pain, and during that visit, he's found to have severe coronary artery disease and heart failure. He tells the medical team that he's in jail for violating parole, and he says, I'm actually really glad that I was in jail because I got to find out what's going on with my heart. Right. So we didn't really talk about this, Professor Song, but our medical system is so messed up that the response here is that at least I'm getting medical care through the jail on subsequent visits, when that wasn't actually even what was assigned, right? So I think there's So one other story, and I know that you mentioned this in your paper. We have an older gentleman coming in after having a debilitating stroke in the emergency room. They're intubated and sedated. They're in the intensive care unit for about 10 days, intubated, sedated, but still at that time, handcuffs to both guardrails and shackles on the arms. Right. This is again somebody who's intubated and sedated. Subsequently, they're able to be extubated, and we find some significant wounds from the shackling, and really not being able to move because of the sedation. And it takes about 3 days of advocacy by the medical team that goes up to various levels within the jail system to be able to remove the handcuffs and shackles for this person to be, one, able to have a neurologic exam that was necessary after having a debilitating stroke, and two, to be able to work with physical therapy and the other therapists for the medical care that they needed, right? So a direct sort of opposition to what was necessary from a medical standpoint to be able to provide the necessary care, and delays in direct care because of the carceral system, right? So I partly, I know you talk about this from the larger framework and the legal framework and the policy framework some in your piece, and every single part of your paper resonates very deeply with particular stories that I can sort of attach myself to. So I really appreciate you kind of bringing those forward. One of the things that I think you talk about in the paper that you didn't bring up right now was sort of what are the legal and financial arrangements between jails, prisons, and hospital systems, right? So many jails and prisons have legal arrangements, in particular with safety net facilities, and nonprofit, for-profit hospitals, and so going back to what are the incentives or disincentives for hospitals at the system level to work with or not work with, and in what capacity and what sort of caliber to work with or not work with prisons and direct individual cops. I think that financial piece is a critical piece to sort of think about. So, as I mentioned, we call, I think about the ingrained carceral logics in a lot of folks that work within healthcare, not just at, say UTMB, where you are seeing high number of patients who are incarcerated. But even if you don't work within that setting, a lot of times the defaults for framing of mental health or behavioral health crises are involve sort of the security apparatus or sort of carceral logics as the most consistent way to do that. So what are some of the things that at the micro level, at the sort of clinician level, we can do to challenge policing and carceral systems, and certainly again the logics of that, right? This question of how do we get, as care providers, how do we get the cop out of our head? How do we get the cop out of our heart in terms of the day-to-day work that we're doing? So I think one thing that we need to really think about is how do we reimagine shifting power dynamics, both between providers and patients, as well as between healthcare systems and healthcare providers and prison systems, right? So one of the things that we've been doing over here, again, this is at the local level, and we've been working with a number of community experts to lead power mapping sessions with our trainees and some of our staff to really understand what are the dynamics of power within a clinical space, right? What are the dynamics of power within a hospital room? How does that change in the context of, say, practicing medicine in a hospital room where there's a prison guard or a cop present, and trying to understand how power manifests itself, and overtly naming that, and then trying to imagine, right, how it can be shifted, right? So I think this is really a practice of how to make visible the power relations that are often normalized or invisibilized, and challenging them to say, okay, what would it actually look like to provide the most compassionate care in this space, right? As opposed to taking it as a norm, well, this is how we did it during training, or this is what I saw, or I've been doing for the last 10 years sort of thing. You mentioned abolition medicine a little bit, right? So abolition medicine, really calls for divesting from practices within healthcare that perpetuate systemic racism, that criminalize the lives of marginalized people, and also in reinvesting in life-affirming systems, right, that address structural harm. And so, in a lot of ways, going back to this question of what is the relationship between hospitals and police systems or carceral systems, is it possible to disentangle them? Have they grown up together? As you mentioned, the history actually aligns really well, and I think that in many ways the logics of both systems are carceral logics, right? And so how do we actually think about redirecting resources away from hospital carceral systems, as well as policing structures, towards building a new, maybe changing along the way, the current healthcare structures that we have, right, to be able to really invest in the welfare of our communities and people. I want to mention just a couple of examples, sort of more at the macro level, and this kind of goes back to is it possible to change some of the is it possible to change hospital culture, right? Like, this isn't necessarily a new thing. I think there's been greater alignment in the last 30 years that we've seen, although I don't know, maybe that's just my historical perspective is limited, maybe not. So that, I think at the macro level, this work has to be done in community alongside community leaders. It can't be isolated to just hospital administrators or hospital leaders trying to push in a certain way. I think the legal framework, as you mentioned, right, are there things that JCO or CMS or can push? Are there legal policies? I think that's necessary, but I think really trying to think about how do you reimagine what healthcare can look like outside of a carceral logic has to come forward by through community leaders, community activists who are advocating for justice and care. So one of the examples here locally, so following the death of Michael Ramos in April of 2020, followed by the death of George Floyd in May of 2020, a number of community leaders and organizers and activists, came together and put a lot of pressure on the city of Austin, to create a reimagining public safety task force that was really tasked with how do we really redefine public safety in several realms, right? Not just in policing, not just in hospitals, not just in mental health care, but sort of in a much larger process. This was a community engaged process over several months that really centered the voices of those who were most directly impacted by harms from policing. Brought in some healthcare workers, brought in some social care workers, social workers, and others, and so I really encourage y'all to check out if you just use your search engine of choice and put in Reimagining Public Safety Austin. The entire timeline is there. The process that they went through, the public, all of the meetings were made public. There's a whole history of policing in Austin and actually around the world. That's a part of that, and the recommendations are a part of that, and they're really quite tremendous recommendations. Many of which have not been able to be enacted, but some, have been able to be, move forward. So one of the things that really came out of this is that there was a direct calling out by community members that healthcare, as you mentioned, Professor Song, often functions as the pipeline for police to criminalize people seeking care, and that, we need to rethink at the community level the policies and the interactions between the health systems and the carceral systems, right? So it can't just be done by the hospital systems. It can't just be done by people who work within the hospital systems who, again, have had a history of, I work within this system. The cop is in my head in many ways within these systems, but it really also needs to be done and driven by community leaders. One other example, and I think this intertwines with this question of to what extent hospitals should be involved at all with care for people who are incarcerated, and is there a possibility that it shifts the care structures, if that's possible, within carceral systems, or is that not even a possibility, right? So here in Austin in 2021. There was, this goes back several years, but the Travis County Court of Commissioners was ruling on whether or not to fund a quote-unquote trauma-informed women's jail here in Travis County, and there are similar initiatives, around the country in several different cities. And again, a number of community organizers and activists, along with healthcare providers, social care providers, came together to say, what we don't need is healthcare located within jail structures. What we don't need is more jail structures. What we need is all of that money funding community-based mental health care, community-based substance use, related care, behavioral care, all of those sorts of things. Not another jail where clinicians can work within the jail, right? So how do we actually dismantle the idea that what we need is another jail and better care within the jail, to say what we need is not another jail and better care outside in the community. Yeah. Sorry, I know that was kind of all over the place. I apologize, but thank you so much, Professor Song.
So thank you, and I really want to get to questions. So I'm just gonna, because you absolutely highlighted a few things that I didn't mention, which is first I want to start with this community. The community voice. So I absolutely think that one of the key things that, and a lot of medical providers are already doing this, in Austin, and there are other places in cities across the country, about figuring out how to partner with community voices to say, this is our experience. Because I think a lot of the dominant voices, like workplace safety, this is the reason why we need police, versus you bringing in police actually makes this unsafe for me, right? And so this is how we would like to see our care. But then that makes me think about another thing, because I'm talking to law students also here, which is, so I'm part of this organization and the Pacific Juvenile Defender Center, and recently we started doing sort of collaborative advocacy. And I think we're off. Are we off? Or are we still on? I'm recording, or I just okay. Okay, so the idea, if you think about it, is like, how is it that lawyers can partner with community voices? Not because we're going to lead, right? So this is also like about movement lawyering, right? And like, not that you're leading the charge, but you're hearing what the community has to say about what the problems are, and then you, as good lawyers you are, you're issue spotting and then helping to navigate, but really working with alongside people in order to craft outcomes, right? So no longer are we in a thing where we sue someone and come up with a consent decree that actually doesn't address a lot of the micro issues that are valuable to people who are impacted especially, but that you're doing it together. And then the other thing I wanted to mention is costs. I know I saw that page and I was like, that's so complicated, I'm skipping over it, so I'm glad you brought it up, because costs are huge. Costs are the reason why, I mean, we all operate, and hospitals are under huge financial pressures. And I don't actually know how the costs play out here. So when I mentioned EMTALA sometimes is talked about as an unfunded mandate, meaning that it's a requirement that you medically screen at the hospital, but it's actually not really unfunded, because if you're a Medicare or Medicaid person, then the federal government is providing funds, or the state is through those healthcare programs. So there's this thing where, like, if you're in custody for longer than 24 hours, then your Medicare and Medicaid eligibility stops. So that's a Medicaid something exclusion plan or a policy. And so that has begun to change in states. So because people were realizing, hey, like, so someone goes into custody, then they get kicked off, and then now someone gets out 3 days later, and then we have to enroll someone enrollment is a nightmare, right? And you need to have someone help you. So then I'm like, I'm not sure. So like, if you have at the same time like Medicaid being expanded in some way, and then you're like kind of like building in costs maybe on the other hand, maybe, but I do think that bigger question, like when I talk about CMS regulation, that, oh, then hospitals be like, everything's gonna be too costly. It doesn't, I still think by and large, the costs, because I think the costs that hospitals aren't taking into account are the costs to the providers themselves that happen kind of, I mean, when I'm talking to some of these trauma surgeons, they're like, yes, on the days when I can deal with it, then I deal with it. But sometimes I'm just too tired. And so you see that it's a thing that medical providers grapple with constantly. And so I think that's one hidden cost. And then there are other bigger, I think, societal costs when you think about access to healthcare. And then I had all these things. I was like, oh, add that into this already long paper. So then I'm like, I don't know how much I can add. But I think I just wanted to end by saying thank you. It does help to hear a physician talk about it. And I think that when I made the switch over from practice to academia, my biggest promise to myself was that I was continuing to research and write on things that mattered. So your response was very important to me, because it made me, even your comment that it resonated with you, I felt was really gratifying. So thank you, and thank you for your comments. And